different times. So the average age, not saying that any woman's average, but the average age is 51. But some women have an earlier menopause. Sometimes it can just run in families, but sometimes someone can have a menopause forced on them. For example, if they have their ovaries removed, they'll immediately become menopausal. Or if they have their ovaries damaged, for example, if they have a type of drug such as chemotherapy for cancer or radiotherapy, for example, they will become menopausal. Now, the menopause is associated with symptoms for most women. A lot of women think about flushes, sweats, which occur in a lot of women, about 75%. But there are other symptoms which we'll talk about, I'm sure, but symptoms such as brain fog, memory loss, fatigue, poor concentration, joint pains, muscle aches, headaches, migraines, urinary tract infections, just generally feeling flat and fed up. And you can see that a lot of women won't realise those symptoms are actually due to their changing hormone levels. But I'm, as you know, a physician, I'm not a gynecologist, but I'm very interested in disease prevention. And we know that when women go through the menopause at whatever age, they have an increased risk of diseases such as heart disease, diabetes, osteoporosis, dementia, and clinical depression, because hormones work on every cell in our body. I can't think of one cell where we don't have an estrogen receptor. And evolutionary, we're designed to sort of expire and die quite soon after our menopause, and we don't, thankfully. We live for decades, but without the hormones it has real tolls on our body. So for example, a woman has a 5 times increased risk of a heart attack without her hormones. So although menopause is mostly a natural process, there are real health risks with it. And certainly for me as a clinician, I don't want people to be coming to see me as a doctor. I want them to be enjoying their lives. And for most women, the menopause can affect us for a third of our lives, around 30 years. So we need to make it a really positive experience, but also a really healthy experience. So a lot of my job is about empowering women, actually, giving them the right information, so then hopefully they can make the right choices about their future health.
So you mentioned symptoms there. If I can come to you, Michelle, one of the symptoms that you experienced, that you bravely wrote about in a national newspaper, was your libido disappearing, and you being quite confused by it, and then you had to go out and educate yourself, and you realised you were going through the perimenopause.
Yeah, I think it was, I've always enjoyed a very active sex life, you know, been with my husband over 18 years now, and I've noticed over the time that, you know, there's certain times in the month that I just really do not fancy engaging in activity at all. So I had to go and do my own research. And, you know, I'm somebody that's quite, you know, intuitive, want to find out more, want to know more. And you know, me as a personal trainer, as a life coach, and someone that's really into fitness, I was confused. So I actually think to myself, if I'm like that, who wants to go and explore more, normal everyday woman, how's she going to feel? You know, so I would say I'm still in the perimenopausal stage, which obviously I've got a massive supporters now in Louise and Kate to help me when I'm actually there. You know, just that little bit of added information, and it helps with your confidence. You know, so there are times of the month that I call it the 10-day span. Me and my husband laugh about it now. You know, where I just feel like, no, not after 10 days, I'm not engaged, and that it's another 21 days of like, okay, what's next? So it is about, you know, almost finding out and having that I call it your toolbox full of information that can help you, and that you can then transport and empower other women and couples with that information.
Yeah, because we need to educate the men in our lives as well, don't we?
Absolutely.
Kate, if I can come on to you, you are writing a book called The Great Menopause Scandal. Can you tell me about your own experience and what inspired you to investigate the menopause so deeply that you are now writing a book and producing a documentary?
Yeah, well, I used to be the film critic at the Times, and I had the most god-awful perimenopause, a complete car crash. And I think of it as a sort of Thelma and Louise car crash that went right off the cliff. And I went to my doctor a couple of times, my GP, with heart palpitations, sweats, and I was still having my periods, so I didn't even know what it was. And they gave me tests for my heart and everything. They said, you're fine, off you go, drink less coffee. Anyway, it turned out to be my hormones. Terrified to go and get HRT from my doctor, and no help. So I went privately. I got bioidentical hormones in lozenges from a very good looking private clinic in the middle of London, recommended by friends. turned out after a year, it was fantastic. All my symptoms went away, my mental health problems improved. It really worked. But suddenly I think I got a bad batch of hormones from this particular clinic. And I suddenly got terrible bleeding. I had to go back in. They gave me a scan. They said, oh, you're all right, off you go. We're going to change it a bit. And then they gave me more hormones. And then I went to the hospital and they said, you're on the cancer fast track for uterine and cervical cancer. We're going to test you and take biopsies. And I was really lucky that I got caught early and I came off the bioidentical hormones, which I paid a lot of money for, and actually ended up in Louise's surgery. And she gave me the natural regulated hormones that are available on the NHS, which my doctor could have given me 3 years before, and none of this need have happened. And I didn't even know about them. And I realized this has happened to me. I'm an investigative journalist. I researched this clinic. I asked all my friends. I looked it all up and I got it completely wrong. So what happens to regular women with this sort of level of injustice and ignorance? And the more I dug in, the more it was a story came up every day. And half the time I was in tears. And one of the stories Louise told me was about a woman in perimenopause who had gone in and got 12 sessions of electroconvulsive therapy because she had incurable depression. And then 7 years later, she got hormones, and 4 days after that, walked her dog for the first time and went out. And I realized the scale of this problem is massive, and the ignorance of perimenopause is massive. And GPs don't know what they're necessarily doing, and some of them don't know what to advise. And so I thought, this is chaos. We have to go in and do something.
And why do you think there is this mass ignorance of perimenopause, which, by the way, is a phrase that I'd never even heard of until I started experiencing symptoms, and I'm the editor-in-chief of the biggest health publishing brand in the UK. So if I'd never heard of it, it stands to reason that millions of women haven't. So, but why is there this mass ignorance, in your opinion?
Well, I think Louise could talk to the medical bit of that, but in terms of the cultural bit, we're afraid to admit we're going up to menopause. And I think what Michelle is saying, I'm in perimenopause, hear me, is fantastic. But I think we just don't want to believe it's happening to us. And also, nobody ever told me that happened to me in my 40s. I thought menopause is going to happen after I'm 50, and my periods will stop and it will all be fine. And there's no discussion, or until the last couple of years, there's been no discussion in the media, no conversation, and no conversation with my friends. I wasn't in a circle of women who talked about this. And maybe with a lot of working women who just got on with it, but I think no one's talking about it, and we need to really, really shout. I think it's incredibly important, particularly in terms of mental health. I think it's a huge estrogen, what it does in your brain is massive.
Absolutely. So there's this misconception that the menopause is simply just hot flushes, and that it's almost a badge of honour to endure it without any HRT and any assistance. And I certainly think that's I think in the area where I'm from, in South Wales, in the working class South Wales valleys, that women just don't want to take HRT. But I think there's a lot of misinformation out there about HRT and the alleged cancer risks, etc. If I can come back to you, Louise, can you shed some light on that for us, please?
Yeah, it's really important, isn't it? So we know that the menopause is a long-term hormone deficiency, and the perimenopause hormones start to decline. As soon as you talk about a deficiency, the obvious thing is to think about replacing. And if I said to someone they were low in vitamin B12, they would say, well, how do I get that? If I was low in iron, how do I get that? If you were low in insulin because you had type 1 diabetes, well, you would give yourself insulin. We are low in estrogen, and a lot of women are low in testosterone. So isn't it the most obvious thing to replace it? But the words that we use really scare people. So those 3 letters, HRT, hormone replacement therapy, scare everyone senseless. And there's reasons for this, is that because we've had studies in the past that have shown there's potentially a small risk of breast cancer with some types of HRT, not all types. And those have been reported and misreported, not just in the media, not even just to women, but also to healthcare professionals as well. So people are really scared about HRT, and people will do anything to avoid it. And as you say, Claire, you know, people think they'll battle through, they'll cope with the symptoms. Even Michelle saying, you know, she has this time in the month that's hard. Well, that's just because hormone levels are lowering. But actually, we don't get any medals. We don't get a card from the Queen to say, well done, when we're officially menopausal. Nothing magical happens, apart from maybe we'll lose our jobs, or our partners will leave us, or like this poor lady, she'll become sectioned because her brain didn't work and she was so depressed. So we have to think about what are the good things about HRT? And I'm going to say a few things about the good things first, because it's always about bad things with HRT. Now, the good things about HRT is it's replacing the hormones, but actually in the perimenopause, it's topping up the hormones. It's not a replacement, it's a top up, if you like. And when you get the right dose and type of HRT for you as an individual, because we're all individual, then it will improve all your symptoms, because the symptoms are due to the lack in hormones. So that's a good thing, because people can think better, they can exercise more, they can sleep better, you know, their symptoms will improve. But more importantly, I've already said there's these health risks when women go through the menopause. We know that when women take HRT, they have a lower risk of all diseases, actually, including from cancer, if they take it in the long term. So that means they have a lower risk of heart disease. Most women die from heart disease, and taking HRT reduces risk of heart disease by about 50%. It also reduces risk of osteoporosis and type 2 diabetes. It even reduces the risk of becoming obese, which is a good thing, and dementia, which we're all dreadfully scared of becoming, you know, having dementia. We know that women actually live longer if they take HRT. We've got studies for 20 years showing that. So why is everyone so scared, as you say? They're scared because the Breast Cancer Association, and we need to unpick the evidence properly. So there's a few things about that first. If a woman's under the age of 51 and takes any type of HRT, there's no increased risk of breast cancer, because she's just replacing the hormones her body would otherwise produce. If she's over 51 and has had a hysterectomy and just has estrogen, maybe testosterone as well, she actually has a 25% lower, not higher, lower risk of developing breast cancer, and actually a lower risk of dying from breast cancer as well, because we know estrogen is actually very protective. The confusion and the concern comes with the old types of progestogens. So a woman who has a womb has to have a type of progestogen to protect the lining of the womb. Now, in the past, we used to give synthetic progestogens, so the same type that's actually in the contraceptive pill. And those have been shown to have a very small increased risk of breast cancer. But when you look at the magnitude of risk, it's less than a risk a woman has if she's overweight, or if she drinks a couple of glasses of wine a night, or if she doesn't exercise, because those lifestyle factors increase a woman's risk of developing breast cancer. But as Kate said, we prescribe now the body identical hormones, so body identical progesterone has never been shown in a study to show an increased risk of breast cancer. So even if a woman takes the synthetic type of HRT that might have a small increased risk, a lot of women taking HRT actually feel better, so they're exercising more, they're sleeping better, they're drinking less alcohol, they actually lose weight as well. So their risk factors for breast cancer lower because their lifestyle improves, even if they're taking the worst type, if you like, of HRT. But we also know by taking HRT, they have a lower risk of heart disease, diabetes, osteoporosis, dementia. So when you put it all in the pot and look at the balance, it's quids up for everyone, because we know from the guidance, we've got really clear menopause guidance that is UK based and international guidance as well, that for the majority of women, the benefits of taking HRT outweigh any risks. Yet sadly, across the world, the minority of women are taking it. So there's a real shift we need to make, and we need to think, why are we not taking a replacement hormone, rather than why are we taking it and we feel really embarrassed and we shouldn't tell our friends we're taking it. And it's about a mindset, and that's really difficult to change, actually.
That's what we're going to try and do in the documentary with Davina McCall. And Davina has been on the front page of your magazine, hasn't she, on the cover? And that was quite an issue that was really popular, wasn't it? Davina talked about her menopause, and she's going to talk about it in the Channel 4 documentary, which will be out in March. But one of the big things is overturning this fear of HRT, but also saying the more knowledge that women have about the menopause, whether or not they take HRT, once they're armed, everything is easier. And what we've got is, you know, all young women are talking about period poverty. I think for the menopause, we're talking about a poverty of knowledge. And if we could get over that, it would be fantastic.
I think we need those resources, you know, and we need them to hand, you know. And I think you spoke about mindset there, Louise. A lot of this is mindset as well, changing that shift of mindset, but you won't do that with confidence unless you've got the knowledge, you know. And also as well, we have to emphasize that one brush doesn't sweep all. Do you know what I mean? You know, one size doesn't fit all, one brush doesn't sweep all. So it's probably identifying that it's down to the individual as well, you know. So I think that's
absolutely, and certainly, you know, the guidelines, the NICE guidance we use in the UK, the National Institute of Health and Care Excellence, are very clear that it's individualised advice that women need for their perimenopause and menopause. And clearly I've talked about HRT, but there's no point taking HRT, sitting on a sofa, smoking 20 a day, drinking 5 pints of beer every evening. It's looking holistically and looking, but actually, as you know, when you become perimenopausal or menopausal, it can really affect the way you think, the way you concentrate, the way you work, the way you are. So actually, we want to be educated before. I had symptoms for a few months, and even being a menopause specialist didn't recognise them because I was too busy thinking about setting up my website, doing everything else. So we need to be educated really early, a bit like my children have sexual health education when they're hopefully not sexually active, you know. Yeah. But that's really important. So it's out there, we're talking about it, so that, you know, a lot of patients I see, just for me to tell them they haven't got dementia is so, you know, it frees up their life so much. And that's before I've spoken to them about any form of treatment. And it is the whole, you know, knowledge is power, and we need choices. And, you know, sadly, a lot of women have that choice taken away because they're told by their doctor they have to have an antidepressant or they can't have HRT. And, you know, this is what's really sad for me as a healthcare professional, because so many doctors, nurses, pharmacists, healthcare professionals have no training at all in the menopause, yet they will all see adult women who will all have the menopause. So there's a big shift that needs to happen, because as Kate said, she had palpitations, she had heart tests. What a waste of money for the NHS, actually, going to a hospital for heart tests, when we know we have a treatment that would melt the palpitations away. And since she's been on HRT, she hasn't had any palpitations. So, you know.
But this is so common. 11% of women who are menopausal or perimenopausal have heart palpitations. Once I knew those sort of statistics, I thought, why doesn't the doctor know? And I know you did that brilliant survey, Louise, about, it was in the British Journal of Family Medicine, about how much doctors actually knew about prescribing HRT. And I think 48% said they weren't confident about prescribing it, or a figure around that area. And I thought, oh God, if half of them don't feel confident, you know, what on earth are we doing here as women? And I always believe what my doctor tells me. That's the problem, isn't it?
And doctors cash generalisation. So I went to my GP at least twice and was turned away because I was too young, because I was in my late 30s and you're too young to have menopausal symptoms. And when I put something up on my Instagram on World Menopause Day about I'm 42, I'm very fit to take part in fitness competitions, but yet I take HRT, several women commented saying, but how did you get it? Because my doctor won't give it to me. So you were all founding members of the Menopause Charity, the very newly formed Menopause Charity. What is it that you hope to achieve through this charity? Is it as basic as just getting this information out there far and wide? If I can maybe come to you, Michelle, because I know you've recently joined as an ambassador.
Yeah, I think for me, which I'm very glad to join a group of women, you know, with the knowledge and the enthusiasm to make changes and make big changes. I think for me, it's just being able to get the message out there to, you know, within my own community as well, you know, and I'm not ashamed to say it, that as Black women, we're very scared to talk about, you know, the menopause, because our grandparents, our mothers never spoke about it. You know, I would see my mum sweating in the kitchen, and I say, Mum, you're right. Yes, it's just a hot flush, and it'd be nothing more than that. So it's about us now, as the new generation, being able to get that message across. That it's not negative, guys. You know, we're lucky if we're here to go through the menopause. Some women don't make it here, and that's the big thing I want to push. Let's embrace this change, this transition, but let's get ourselves armed with the information to pass on. And that's the biggest message I will always push. Get the information so that you feel more confident to deal with your training, to have an active sex life, to walk out on the street without not feeling, oh my God, I've got to strip off, I'm sweating. Embrace it. And, you know, I know I'm not in the minority there in terms of how I feel. There's loads of my friends that are like, Michelle, I need to know this, I need to know that. But there's also some of their friends that are like, nah, it's all right, I'll just go through it. And like we said, a badge of honor. You don't need no badge of honor. You need to be living your best life. You know, living your best life and not in shame.
I mean, one interesting thing I've noticed, having been on HRT now for 5 years, in fact, is that I'm so much calmer, so much more balanced than I've ever been in my whole uppy, downy hormonal life, which was, you know, I was a roller coaster person and I'm not. And also I do take testosterone as well, along with estrogen and progesterone. And I think that helps me with building muscles. And you probably know more about this, Michelle, but I'm a runner. I don't run much more than around the park a couple of times, but it really has made a difference to my muscle strength and my core strength, and it has been amazing. And I think it would be very interesting for people in women's health to look at what's happening with testosterone. It's a really interesting subject.
Because that's not available on the NHS, is it, at the moment? If I'm not mistaken, that would have to be prescribed privately.
Well, it is available on the NHS, but it's not licensed. So there's up until a couple of weeks ago, it wasn't licensed for any women worldwide, and we actually produce more testosterone than estrogen before the menopause. But everyone thinks testosterone's for men and estrogen's for women. But we have cells that respond to testosterone all over our body, and testosterone can really help with mood, energy, concentration, stamina. It can help build muscle, as Kate said. It can help build bone as well. There's some evidence it reduces risk of heart disease, and a small amount of evidence it might reduce the risk of dementia as well. So it's a very important hormone, and it often starts falling before the estrogen starts declining. So a lot of perimenopausal women will find their periods are still regular, but their testosterone is declining, and they're missing it actually. They're feeling a bit sluggish, just a bit emotionally flatter, not able to exercise the same way as they could. And testosterone is very safe. It's not licensed, not because it's not safe, because women's health is not a priority and menopause health is certainly not a priority. We have got a female testosterone cream that has now become licensed in Australia a couple of weeks ago, and we are allowed to prescribe it privately. It costs about 80p a day, and for something that can really transform a woman's life.
I've got it. There it is.
Yeah.
Androfem.
Yeah.
Not advertising it, but you can get the all different kinds on the NHS as well.
Yeah, so on the NHS, we do have male testosterone that is licensed, and of course, can you imagine testosterone not being available for men? It would be even, it would be dire. So we are, as NHS GPs, we can prescribe testosterone for men, but at lower doses for women. So a lot of things we prescribe in medicine are not licensed. For example, if someone has nerve pain, we give something like amitriptyline or gabapentin. It's not licensed for that use, but it's still a licensed medication, so we can use it. Lots of medications for children are not licensed for children, but they are licensed medications we prescribe. So you can do that if a doctor is confident, she can or he can prescribe testosterone, the male testosterone for women in lower doses, and that's very safe. We're hoping that the Androfem that Kate's just shown will get a license in the UK, and that will make a huge difference for women. It's mentioned in the guidelines, the NICE guidance for menopause, that if a woman has reduced sexual desire despite taking HRT, she can be considered for testosterone. And a lot of the research for testosterone is about sex, and actually in Australia it's licensed for hyposexual desire disorder, which is when people have reduced sexual desire. But actually, as I'm sure you all know, libido in women is not just a hormone. There's lots of else that goes on in us women when we're deciding to have sex or not. And as I've already said, testosterone can help with mood, energy, concentration, motivation, stamina. If you're feeling good about yourself, if you've got more energy, if you're sleeping better, you feel happier, of course you're more likely to have sex. But it's looking at the whole package, if you like, and that's what's really important. But sadly, very few women are able to take testosterone, and I was never taught about the menopause at all as an undergraduate or postgraduate, and certainly no one taught me about testosterone. But I take it. My brain would not work without it. I was becoming very forgetful, very low, my muscles and joints were aching, and I was taking estrogen and it didn't have the right effect. But not everyone needs testosterone. But what's really sad for me as a menopause specialist is there's lots of women who would benefit from it who are not able to get it, and that's something else for the charity to work on, really.
A quick question there, Louise. How do you know when your testosterone levels are low?
Yes, so you can do a blood test. So we do a blood test. You can do testosterone levels, but we also do something called sex hormone binding globulin, which sort of binds your testosterone. So you work out a ratio to see how much is freely available. Now, a low level doesn't mean it's the low testosterone that's causing all your symptoms, if you see what I mean, but it's an indicator. And often, and it's the same with menopause, it's not a biochemical diagnosis. We don't make the diagnosis by a blood test. Even in younger women, we do sometimes do hormone blood tests, but it's more about their story. There's a menopause symptom questionnaire, which is available on my Menopause Doctor website or through my free app Balance. If a woman puts in those symptoms and they've changed, and certainly if her periods have changed, then it's likely their hormones. Which hormone, it's difficult to know, but we often give estrogen first, and then if they're still having symptoms, add in testosterone, and then we monitor them. And then if after a few months they say, do you know what, I don't feel any different, well, it's not their hormones. But if they come back and say, my goodness, I'm running around the park, I'm feeling happier, then you've answered the question. It's actually very simple, sort of obvious medicine, if you like, but because everyone's so scared, and a lot of women tell me they are going to doctors, but they're getting blood tests, and they're told, oh, my blood tests are normal. So say, for example, Michelle, you're quite clearly saying you feel different at different times of your cycle, which is very common when people are perimenopausal. If I did your blood test soon after your period, when you probably feel quite good, your blood test would be normal. If I did it just before your period, your blood test would be really low. So, I could tell you from a normal test, oh, you're fine, but you're not fine. You've already told me. So actually, the diagnosis is by listening to women, actually, and women recognizing it themselves, and that's really important.
So I guess on that basis alone, it's about then empowering women to start really looking into themselves, finding that time to actually identify where you're at throughout the month in order to make a better judgment.
Yeah, and that's what's really important, Michelle, and that's one of the reasons that we've set up this free app Balance, so people can monitor their symptoms, and then you can actually download a health report from it to go back to your doctor. Because what's happening is certainly women are going to their doctors and they're saying, I'm not sleeping, I feel really low, really tired, I'm very tearful. And understandably, the doctor or healthcare professionals, if you might, I wonder if they're depressed. They've got a very quick consultation. By the time that started, they're already thinking depression, or they might be like, Kate, I've got palpitations, I feel more tired. Right, do they need a heart? Obviously, no one wants to miss a heart problem in a patient. So then you go straight to the cardiologist. Whereas actually, if a woman is really empowered, she downloads a health report and says to her doctor, the last 6 months, my periods have just changed a little bit, but look at these symptoms I'm getting. And I've gone to a website, I've got the app, I've gone to the charity, and I found this information. And actually, I've read how safe HRT is in the perimenopause, and I want to improve my future health as well as my symptoms. So what I'd like to do is to try some body identical HRT. I think I'd like the gel because I want something to rub on every day. I know it's the same structure as the hormones I'm producing anyway. I know it's derived from the yam, the root vegetable. I know it's very safe. Can I have it? And then it's a whole different consultation. And actually, you've that time that was wasted by going through all the symptoms, you've given all the information. So if I had a 10-minute consultation, if the patient has led it for the first 2 minutes, I've then got 8 minutes, which is a long time actually, to really go in and talk about how to prescribe and what to do. So it's and the more that we as patients take control of our consultations, the better. It really makes a difference.
I was thinking when you were talking about all those symptoms, so many women do go in for their 10 minutes with their GP and they say, oh, I'm feeling a bit low mood, I'm feeling a bit this and that. And then they get antidepressants. And as we know, they just get handed antidepressants all the time. Women in their 40s and 50s, it's a huge bubble of antidepressants. And of course, that lowers your sex drive as well. That's one of the other additional things, that some of those antidepressants really, really lower your libido. So they're feeling a bit crap. They go in, they've still got sort of periods, and then they get antidepressants, and then they don't want to have sex anymore. And how does that affect marriages? I'm really interested in what Michelle was saying about couples. What does happen there? What are we doing? You know, and
it's absolutely huge, and it's, you know, people that don't have sex, it can be a real. It can affect in so many ways, and we know there are actually health benefits of regular sex. You know, we know from studies in men, actually, men that have sex at least twice a week are less likely to have heart disease, they're less likely to have diabetes, and they're more likely to perform well at work as well. And, you know, we're very British, we don't want to talk about sex, but actually it is really important. So, but not just that, for that partner, they're watching someone that they really love and adore change. They've watched this person go from maybe being quite a dynamic, happy, joyful person who's been in the head of the house, we're always multitasking with our children or cooking a meal or whatever, to someone who's literally staring at the four walls, not interested, not motivated, not even, you know, asking, have you had a good day? Because they have got all their emotions gone. And then this partner's looking at this person they love and thinking, well, what have I done? Is it me? Have they gone off me? And then there's nothing going on in the bedroom. And I have a lot of patients who are from same-sex relationships. And when two of them are perimenopausal or menopausal, it's a nightmare. But there's a lot of people who come and see me who have, sadly, their relationships have broken down, and they think it's because they had a different job or a stressful time in their life, and then they look back and it's because their periods were changing, but no one had alerted them. A lot of my patients have gone to Relate, or they've gone to marriage counselling, and you know, no one's picking it up. No one's saying, have you thought, could it be your periods? And so it's very hard for that partner. And I did a lot of work with West Midlands Fire Brigade, which is obviously very male dominated, very testosterone fueled men, clearly, who are firefighters, and they're not getting sex. They're very embarrassed the way their partners have changed. But how can you go to work and say, do you know what, lads, I'm having no sex, my partner's awful? It doesn't happen, you can't do it. So then how do they find out about it? Because maybe their mother hasn't spoken or their sister hasn't spoken. And so then they think it's me, and then they go and look elsewhere. And it's absolutely a travesty for relationships. And so many women say to me, I really still love my partner, but I'm not interested in sex. And I keep saying to him, I really love you, but I'm just not interested. And a lot of women, as you know, Kate, have vaginal dryness, about 80% of women. And then it's very painful. Someone said to me a couple of years ago, having sex with her partner is like a red hot poker shoved inside her. And I said, gosh, I hope you talked about it to your partner. Oh no, he's so desperate for sex. How can I tell him? And certainly in a lot of ethnic minority groups, how can you talk about that to your partner? It's just, you can't. And how do you talk about it to your own friends? There's not even a word for it in a lot of languages. But you know, the menopause doesn't pick out certain, you know, ethnic groups or social classes. We all have symptoms, and 80% of women will have vaginal dryness, but 8% probably, studies have shown, will receive treatment. And treatment doesn't even include HRT. It's very, very localized treatment. But no one's getting it because they don't know what it is. They think it's part of getting older. A lot of women just say, well, that's just my life. I expect sex to be uncomfortable. I mean, that's wrong, isn't it? So many levels.
It's breaking down the barriers, I guess, as well. You know, it's our job, you know, to break down the barriers. And, you know, I guess that's in ethnic minorities. I'm talking from a Black woman's point of view here. Having that conversation, being open and not feeling embarrassed and ashamed. And I know that's definitely the same in a lot of Asian cultures as well.
Yeah. Is there anything that women can do, lifestyle changes to ease the process? So we're all in agreement that HRT is the best route, advisable route from the medical profession. But are there any, for instance, Michelle, exercise? Are there any particular exercises that sport that women should do in their 40s and 50s that would ease their symptoms, mentally and physically?
Well, I'm going to talk about the mental side of it first and foremost, because that's something that I really do know about. I know that most of my clients in their 40s and 50s, the fact of them sticking to something on a regular basis, you know, 3 times a week, yoga, Pilates, just a walk. You know, I'm not asking anybody to become Olympians at all. What I'm asking somebody to do is start factoring in exercise into their weekly routine. Yeah, so it might be for somebody a 20-minute walk a day. Yeah, rather than saying to them, put them off saying, you've got to do 10,000 steps, you've got to just start factoring a 20-minute walk a day. And the more you build it up, the better it's going to be for you in the long run. So it's about making small steps, but quite early on is what I'd probably more say. So whilst you're not, no symptoms at all, start incorporating a physical activity exercise regime so that it can see you through, rather than thinking knee-jerk reaction, let me start training now. Yeah. I would almost say go back. Before, whilst you're fit, young, no symptoms, kicking butt, start something then, and then keep it going, and then just gradually increasing it and invest in yourself. You know, we're very quick to invest in our children, for example, you know, to go to ballet lessons, tennis lessons, but we always come last. So as a personal trainer and a life coach, I'm saying, guys, let's start investing in us first, because I tell you what, we're generally the top of the tree. If we ain't on our A game, everything else diminishes and falls down. And that's probably the biggest thing to say to people. Just reinvest a little bit of time into ourselves, you know. And I would say, you know, circuit training is great, Pilates is great, you know, just going on to apps, you know, something that's not so, you know, costly, finding an app and following that, because not everybody's going to have a personal trainer. We have to be acceptant of that. Yeah, but get a group of women that can go out walking. So I know more and more women are doing something, but on a regular basis.
And there's so much free workout content online. One of the things that's come out of COVID and the lockdowns that we've endured is that so many people put free workout content on YouTube. Women's Health YouTube, for instance, there's workouts on there. Joe Wicks, you know, 20-minute HIIT sessions. You can just do them in your living room. There's no excuse. And there's also been a lot of research about the benefits of strength training in warding off osteoporosis. But there's a definite fear amongst women of a slightly older age group of lifting weights, because they think they're going to get bulky. And
I mean, I've had that my whole life. We used to have it as athletes, you know. People used to hear people say, oh, you're in the gym so much, aren't you going to look like a man? I used to hear that all the time. I'm like, guys, we don't lift strong enough weights to look like a man. So it's again, but that is diminishing. That statement is diminishing. We want to encourage more women to start being stronger, lifting weights, because it does help, you know, in terms of staving off osteoporosis significantly. So, you know, for me, it's easy because weight training I love feeling strong. Strong, not skinny, is my biggest thing. Yeah. But to educate women that have never done weights before, that is a challenge and something for us to just start doing. So it might be that they walk with 2 dumbbells in their hands. Yeah, I often say to my mum, who's 81 in April, Mum, keep walking in the door with your big bags of shopping.
Yeah.
And that's something, my mum's 81 and she's been doing this for the last 20 years.
Yeah.
You know, walk that little bit longer.
You can get the weights that you put on your arms and your ankles. And
absolutely.
And it's just added weight then. Sorry, Kate, go ahead.
I was just thinking when you were talking about the physical weights and also the mental weight we all have around our sort of late 40s, early 50s, and that we are doing all the things with the teenage children, the aging parents who are sick, holding down a full-time job, possibly at quite a high level. We're all doing that, and we really need to take the time to put down that weight and take up your small hand weights, really, and give ourselves the space. And also think, I got this feeling at one point when I kind of threw everything out the pram, and I said, my God, I've been serving people all my life, you know, and that's why I'm falling apart. I've been trying to make everything okay for everybody else, and I really have to look after myself at this point, and then I can go back to making things okay for everybody else. But that moment where your self-care and your time goes to this size, and even if, like I was still running, but I just didn't have any space for anything else. And I think we've got to give ourselves space and generosity to ourselves, and think about, it's not misery, the menopause, it's a metamorphosis, and it's not just about chemicals, it's about a much bigger kind of philosophical thing for women, and we've got to look at it in a big way, I think.
So we're just about out of time. So if I can just go around all three of you and just ask for your summing up thoughts. So Louise, what is the one thing that you hope to achieve through the Menopause Charity, your newly founded charity, and one thing that you want the women to know about the perimenopause and the menopause?
I just want all women to be able to access evidence-based information, and then they can decide the best journey for them, and to do it in a way that it will just be a positive journey and a healthy journey. So it's information is key, really.
The same question for you, Michelle. What do you hope your bravely speaking out about your own experiences will achieve?
I think I want to empower other women to start taking hold of their own journey. You know, you don't get to 40 and think, okay, my life's over. Start thinking, okay, what's next? Let me go and get it. And whatever resources I need to go and find out about it.
Great. And Kate, I'm very much looking forward to your book, The Great Menopause Scandal, and the documentary. What do you want?
I think one of the things the charity and the documentary and the book are all asking for, which is action. We could take action on this incredibly quickly. We could give women decent information on the menopause, on HRT. We could educate doctors and just make everything easier for everybody. It would take 5 minutes to change those things. They are not complicated. And the other thing I've discovered writing this is that every woman has a story, and it's a different story. We should all tell our stories in public, as we are doing now. And it's so important just to go out there and go, blah, here's my story.
I love that.
Well, thank you so much. This has been Women's Health Weekenders, and thank you, Dr Louise Newsom, Michelle Robinson-Griffiths and Kate Muir for joining me today. I'm Claire Sanderson. I hope that you found this fascinating and that you will take action, and please do tune in for the rest of the workouts and talks we have planned this weekend. Thank you. Bye-bye.
Thank you.